what is airway and how is it relevant to dentistry in a nutshell? What are the things that we as general dentists should be looking out for to work alongside a myofunctional therapist? What problems does myofunctional therapy solve, and how does that assist the dentist?
There's clinicians doing beautiful composite bonding and dealing with edge wear and things like that, and they don't understand why. Why has it happened? Why are my fixed retainers breaking? Why is there orthodontic relapse? And there is something driving that, and we're not very good at taking a pause and taking a step back and looking at the person. We're focusing on the broken retainer or the chipped composite. Why do those teeth break in the first place? Why am I doing composite back on this tooth? Material science shows us how long these materials should last for. If they're not lasting that amount of time, predictably, then there's got to be a reason why.
Implementing airway. Listen, we've had episodes before and we'll have episodes in the future talking about sleep disorder breathing and how dentistry can be involved and the importance of diagnosis and screening. But you know what I'm interested in today in this 2-part episode? I'm interested in implementing, right? How do you actually, what do you do with information? Okay, you find out your patient may have sleep apnea. You didn't diagnose it because we're dentists. We cannot diagnose sleep disorder breathing, but we are in a wonderful place to screen. But when you have that information, how does it influence the care that we can give to a patient? How does it influence how we can help this patient? What do you do with that information? Who do you work with? Let's make this tangible, Protrusive. My name is Jaz Galati and welcome back to your favorite dental podcast. Like I said, this is a 2-part special, and in this part 1 of 2, we're looking more into like an introduction thing, like what is sleep disorder breathing, like it's important. Maybe this is the first episode ever that you've tuned into. Welcome if that's the case. It's important to do like an introduction of that. We learn about Aston Parmar, who's our wonderful guest today. I wanted to learn about his journey. How does one even get involved with sleep? And he's like really niched into it now. So I always love to explore everyone's journey. You learn so much and it kind of inspires us in our own lives as dentists. How can we better ourselves? How can we become laser focused? Maybe sleep disorder breathing is the next niche for you, or maybe it isn't. And you just want to be able to screen and help to refer when appropriate. And what if you want to, but you're in the wrong environment? You're not at the right type of practice setting to be able to implement this kind of stuff. Well, we talk about those things. And particularly I want to know about how Aston conducts his sleep tests and how he works with myofunctional therapists and what do they actually do. When should we refer to a myofunctional therapist? You know, they can help children and adults. And after this episode, you'll feel a lot clearer on when to involve a myofunctional therapist for your patient, be they a child or an adult. And then right at the end of this episode, we leave you on a cliffhanger. We talk about the spectrum of sleep disorder breathing, and we cover one thing called upper airway resistance syndrome. And then in part 2, we'll continue from that. And oh my goodness, part 2 has so many gems. I'm just teasing you for the future part 2, and we get really into the clinical details and you're asking, okay, what does he do at the end of a rehab if his patient's got sleep disorder breathing? How can we work with their airway, with their sleep issues, and how does that influence the dentistry? So teasing you for part 2, but there's so much good stuff that you need in this episode. Now this episode, like most of our episodes, is eligible for CE or CPD. We are a PACE approved education provider, and hundreds of dentists around the world listen to every episode and they answer the quiz and they get their CPD. If you're not already doing that, head over to Protrusive.app, and if you'd like to get CE, then choose either the podcast CE plan, because if that's the only thing you have time for, listen to the podcast and answering the questions, that's cool. I love you. Enjoy. If you want to also access all our masterclasses, learn how to section teeth, learn how to do vertipreps. This year we're also doing onlays, schmonlays, and so many premium clinical videos on the app, over 400 hours of CE. Choose the ultimate plan. But if you also want access to Ask Jaz, our AI, and save you hours and hours and hours, and that's the Infinity plan. So the website is protrusive.app. Now, every single episode, PDP episode, I give you a protrusive dental pearl. Today's pearl is very relevant to something I assess for in my TMD assessments, but it's also relevant for all our patients, because if we're starting to do more screening for sleep disorder breathing, one very simple and easy thing that we can do as dentists is look for the Mallampati Score. Now we'll go into a little bit more in this episode about what that actually is, but essentially you get the patient to open as big as they can and then stick their tongue out as far as they can. And then basically you see how much of the uvula can you see, how much of the oropharynx can you see. So when the patient sticks their tongue out while they're fully open and you're seeing the entire uvula and you can see the tonsils and the arches and everything, that's super. That's a grade 1. And if your patient sticks their tongue out, you don't see any of the uvula, the tongue is in the way, That's a grade 4. And the relevance of that is that for every 1 grade you are higher, it doubles your odds ratio of having sleep disordered breathing. So you'll hear about how Aston uses that as one piece of data. So obviously their history is important, and then things that we examine are important. But it's a very simple and easy thing that we can do. Now, just a little caveat. In my TMD patients that I see, there is going to be a bias. A lot of these patients can't open more than 30, 35 millimeters. And so don't you think that's going to bias their Mallampati score and make it higher? So be wary of false positives. If they have a TMD issue and they cannot open their mouth, then because they can't open their mouth, that's why you can't see the uvula. Not necessarily because they have a large tongue, you see, it's something else. So always be wary in everything that we do of false positives and false negatives. So I hope you enjoyed that little pearl, simple and easy thing to do. And now you know what the Mallampati score is. Let's now join Aston for this part 1. I'll catch you in the outro. But don't forget to come back for part 2. Dr. Aston Parmar, long time coming, my friend. Welcome to the show. It is incredible to have you. We met, I think, just last year in Cardiff. I've been seeing some of the stuff you've been doing. You're a real inspiration. You're a real force, mate. You know, all the training they've done in America, bringing back into UK, and taking I would say, a very good risk, right? Like starting like the one of the first, South Wales dental sleep, a dental sleep clinic in the UK. Like this is the future, right? You are a pioneer. You are a pioneer, Aston. So welcome to the show. How are you, my friend?
I'm very good. Thank you, Jez. Wow, what an amazing introduction. Thank you so much. You're very kind. I don't feel like I deserve that sort of introduction, but yeah, I have a dream and I'm just going to keep on pushing towards it. And it's one of those things where I started to uncover what I didn't know, and I realized how much I didn't know. And that was going to do one of two things. It was either going to bring me back into my shell, or it was going to go and make me try and find out. And I know that I'll never get to the end of it, and that's okay. And so I just keep on driving forward.
It's the whole blue pill versus red pill, right? It's like we had the same thing in occlusion in general, like inclusion with your occlusal study as well. It's like, okay, you can either just stay conformative, keep single tooth, and then live this cushy life in a way, or you can just open Pandora's box and be like, okay, now you answered one question, but it opened 100 other questions, and one of those is we're integrating sleep and stuff, which is I'm just great to see you go into that, and exactly what I want to pull out of you today. Like 2 burning questions right from the start. Okay, like when someone says, I work in, like your patients, they say, oh, I work in logistics, right? And as a dentist, we're like, what does that even mean? What do you even do, right? Now, when you have a chat and you introduce yourself to a fellow dentist, oh, I own a dental sleep, and they might raise an eyebrow. Like, okay, well, tell me more about that. That's fascinating. Like, what do you do? Do you just make mandibular advancement devices all day long? Do you do what do you do, right? And so we're going to find that out. We're going to find out about how it is that you integrate. I want this to be a really tangible episode, because I think it's really good that we have the UK perspective, because I've had American guests or Australian guests, and I think they are, I'll hear what you have to say, but I think they're a little bit ahead of us. And I've said this time and time again. I hope I don't offend the UK, those who are into sleep and stuff in the UK, but I feel as though that they're ahead. But with what you're doing with the British Dental Sleep Medicine Society, probably got that wrong. What Riaz is doing, what you're doing.
Well, now it's the BSS, it's the British Sleep Society now. Yeah, they've actually amalgamated a little bit tighter. Yeah. Good. We need more unity, right? And so that was one burning question. What do you actually do? And we'll get into that in a moment. But here's a fun one, right? Do you know that if your name is Peter, you have more affinity to a Pepsi than Coca-Cola, right? It's just one of those things that you read and like, oh, that's interesting. The most common name for a dentist is Dennis if you're a guy, or Denise if you're a lady, right? And that's one of those things. Now, do you own an Aston Martin, or do you have an affinity towards Aston Martin? I'm just genuinely interested. Yeah. No. No, I don't. I've spent basically all my money on education. I've got a very, very supportive wife. Maybe one day. I've got a number plate that needs to go on an Aston Martin at some stage, even if it's only for 6 months. The only thing is I'm a bit of a petrol head, so the type of Aston Martins that I like are very, very niche and going to be very, very expensive and very, very rare. But one day. No, I was actually named after a little town in Buckinghamshire called Aston Clinton. My dad was just driving through there, and I was like, oh, Aston. So I could have been Clinton. So I think...
Is your middle name Clinton?
No. No.
Okay,
But one day
that'd be
when I get my
the
Aston
full
Martin, I'm going to
story
come
there.
pick you up, Jazz. We'll go for a ride.
Mate, that'd be awesome. We can even record a podcast then as well. Who knows what the future holds in this amazing space that you're in. So let's dissect it from the start, right? So I always like to start with one's journey. You already scratched the surface a little bit in terms of not knowing things and wanting to know things. And instead of hiding in a shell, you put yourself out there and you've spent a lot of money on education. So let's unpack your journey to the South Wales dental sleep as it is at the moment.
Yes, so it's a very long, so I'm going to try and keep it conducive to happy listening for a podcast. So basically, graduated in Leeds in 2010. I moved to South Wales. My sister's a dentist. She's 4 years older than me. I was of the generation where VT was done on handshakes and things like that. So I basically got to know my sister's old VT boss, and he invited me to come and work for him, which was great. And I learned a lot. I was only supposed to be here for a year. Me and my then girlfriend, now wife, were supposed to go off to Australia. It was of the time when the first of our buddies at uni got married, and we were on the uni table, and of the 12 of us, only me and one other guy didn't do the Australia thing. It was crazy. Like there was
Wow.
it was
real crazy at that. Yeah, you're right. About 2010, 2019,
Yeah.
those who qualified in 2009, 2010, maybe in 2011, there's a big percentage that did Australia and New Zealand.
Yeah, so I was going to go and do that, and then basically, long story short, 1 year in Cardiff has turned into 16 years in Cardiff, and so I just doing NHS work. I was very driven. I've always been good with my hands, generally poor academically, and so I just did NHS work, and I was just, hell bent on trying to churn out as many UDAs as I possibly could. And then, but I'd say the biggest influence for me was one of my buddies. He was a pharmacist. He was a failed dental applicant for dentistry. And then I spoke to him around 4th or 5th year, and I said, dude, you need to go back and do this. It's not the right thing for you to do pharmacy. I think dentistry is the right thing for you. Anyway, he went back to doing dentistry, and then he felt like he was like very far behind the trend, because obviously he was sort of 4 years behind us. And he was absolutely super razor sharp on where the best education was. And so he basically, between the two of us, we he's my best man at my wedding, and I was the same at his. So we absolutely trust each other. And he said, there's this course out in Ukraine. This guy is residential. It'd be fun. We'll be able to spend a couple of weeks together, and we're going to learn some good dentistry. So I heard about this guy called Max in Belgrade, and that was kind of the first pretty good quality education that I started to go and do, all done under microscopes. I'd done a couple of other bits and bobs of education, but nothing structured. It was only ever CPD. And that opened my eyes up into thinking, right, wow, really, like the bits and bobs of CPD that I'd done for the first 5 or 6 years hadn't been high tier. I didn't have a big plan. I was just hell bent on trying to churn out as many UDAs as I possibly could. And then that forced me to stop and pause and self-reflect a lot and work out, actually, for me to be able to do this type of dentistry that Maxim was trying to show, and just be quality focused and slow down. That forced me to then, that was the start of the Pandora's box. That wasn't quite Pandora's box open, but that was the peak inside the treasure chest. Mm-hmm. Then I carried on, and basically fast forward another 3 or 4 years, I'd heard about this thing called COIS, the COIS Center. Now, I had heard about it in my VT. One of the trainers, I spoke to him. He was really into his bonding, and I said to him, I was like, what was the most pivotal sort of moment in your career in terms of education? And he said he went and did a couple of units at COIS. So I'd first found out about it at that point, and I Googled it, and it was crazy expensive, and I was in my VT, and it was just like, okay, I don't really understand. I wasn't that bothered, and I didn't see how it was going to make me more money. Basically, I didn't see how it was going to help my sort of NHS work at that point. And then my buddy went and he signed up to it, and he said, come and do it with me. And I was like, I don't know if I want to do that yet. And so I waited for him to go.
This is the same buddy
course.
that you guys went Ukraine together, right?
Yeah.
Okay.
And so I said, well, you go and do the first one and let me know. And then he phoned me up after day 1 of module 1 and said, dude, do you remember when you phoned me and told me to do dentistry and it was going to cost me like another 100 grand in education and whatever? This is the phone call for you. I can still remember it. He's like, book it all. Thank me later. And literally now I'm the same to anyone that, everyone, there's this famous saying about like, how do you know that you've gone and done course? It's because someone will tell you. And it's because, people think, oh, it's a little bit like culty or whatever. It's just like, no, it's just because it is just, for me, was the elixir of the dental life. And so I want to try and spread that energy and that knowledge amongst amongst my peers, anyone that will hear. Right now, I think
I've never done Kois CE, but I've learned from Kois disciples, been to like 2-3 day lectures from people who've learned from Kois. I've met so many Kois graduates. I've seen Kois himself lecture a few years ago at the AES. Phenomenal. I think it's a great institution from what they pump out, and having alumni in yourself is very encouraging. So I always say in this podcast that whatever occlusal religion or whatever pathway you follow, just go all in and really give it your best. And Kois is definitely a serious contender for everyone.
Yeah, absolutely, exactly. Yeah. And what I'm saying, it's not like you have to be Team Kois and we're not going to be friends. It's just exactly as you said. It's go into it and make a commitment. And so I was really at the point of like, so I'd saved up a bunch of money and I was literally I was like, what do I do with it? Do I invest it into stocks, into Bitcoin? Do I buy a property, whatever? And so I saw it as an investment, and actually the returns it's an absolute no-brainer, even if you just break it down purely from that perspective. But luckily, I also really, really love dentistry, and it was giving me the things that I needed to really like fire me up and push me down the right direction. And it needs to be exactly as you said, you're all in. You need to get your receptionists on board, you need to get your nurses on board, you need to get the practice managers on board. I don't actually own a dental practice. I work in 4 different dental practices, and then I run the sleep clinic, which is predominantly an online thing on the side, and a growing amount of lecturing and things like that as well.
Oh my God. Okay.
Yeah. So
all right, so I'm even more pumped and excited now about your workflow. That's really cool. So look, one thing I must ask, because a lot of people are thinking this, is when you went out. So basically, when you did Kois is an example of really going deep into one channel. So, for example, some people in the UK will go deep into the Aspire course or Chrysor, or if they go abroad, they might choose Spear curriculum or Dawson, whatever they might choose. They go all in. But exactly, Pankey is another great one, right? So many good ones out there. But when you do, right, this is the chicken and egg kind of question, because and as you've experienced, you can go on the best course in the world, but if you're not in the right environment, implement it, it's a huge waste of money. So when you took that big financial risk and you took this extra CE or CPD, flights and stuff and the whole program, were you already in an environment to practice it, or was this your ticket into the environment? Because sometimes that's how you do it. Sometimes you get the CE and then the education, and then that then allows you to play into the league or the environment that you want to. So what was it? How did it work for you?
Yeah, so for me personally, so at that time I was working in 3 practices. So one of them was my sister's practice. So that was I was very lucky that actually effectively I was sort of almost like clinical lead at that practice. And so I had some opportunity to be able to remold things, but that was still a practice that had a NHS contract and a large DPAS contract, as well as pay-as-you-go private. So there's lots of other different, so we couldn't just stop, pause and rewrite the whole business. And I was able to give enough value to the practice, not only just because she was my sister, but also up until that point, I'd proven hopefully that was enough for her to trust me and her to be able to say, yep, cool, like if you believe in this, then go with it. And I was able to have given enough to even the other 2 practices, I hope, for them to give me the time of day for me to be able to explain to them what and why I'm going to go and do this journey and what it's going to mean for them and how it can be a win-win all round. And I can't just go to a practice and say, oh, by the way, I want all of these protocols changing on reception, and a patient isn't allowed to book in with me until they've filled out the questionnaires and things like that. That's first of all, you need to go about it in the right way, and second of all, I needed to have built enough goodwill for them to have bought into me as a person. And so I was in some of those practices morphing them and allowing them to see what the new type of treatments are going to be able to be offered, and therefore the value to those patients and the value to that business. But also in one of the practices, it was quite a new practice and it was starting out and trying to do the right thing. And so actually that was already, the mindset was like, okay, cool, we're not set. It was a bit of a startup. It'd only been running for 18 months or so. So actually it was the right time for me to be able to say, actually guys, let's build this in this manner. And so we were able to get those patients. So it's actually, I wasn't really in one camp or the other camp. But I think, Jazz, the biggest thing is
not
not
a young dentist listening right now, right? Who's maybe not in the right environment. Okay. So what would you say to them? Would you say to them, and this could be for any course or serious investment they make in themselves. This could be like a year-long thing that they do before they put that time and money into it.
Yeah.
Would you advise that they find the right environment and practice and mentors first before getting into that kind of investing in themselves in that way? Or would you advise, doesn't matter where you're at, just go and learn and then help use that as a as a way to get to the right environment? What would you say?
I would say it's not quite black and white, one or the other. I would say you need to be maybe 60% of the first one, because if you don't have the patience, then it will be lost in terms of the knowledge and the hand skills. If you cannot apply it, then you're dead in the water. However, you don't have to have had every single planet lined up for it to be a perfect journey. And so there is a little bit like you need to be able to jump and be able to utilize it. If it's an absolute scenario where it's impossible for you to be able to do any of that work, then maybe wait or change or pivot or explain to the practice and say, listen, this is my plan. Can we change and manipulate the scenario to be conducive to allow me to bring this in-house? And you never know what they might be able to give you. They might be able to give you more time or take some pressures off from elsewhere, things like that. But ultimately, if you don't have the people around you that actually believe and buy into you, then that's actually a bigger issue than your lack of dental knowledge.
I 100% agree. And I'm so glad you said that, because it leaves options open for everyone. No matter what environment you're in, it allows you to, before you make that investment, it allows you to really look at yourself in the mirror and think, okay, where am I now? And then if you feel as though it's not conducive, then what are you going to do? You need to change. And we've said this time and time again, the podcast. In fact, there's an episode with Laura Bailey, therapist I work with. It's just called Massive Action, taking massive action. So sometimes to make that investment in yourself, in your education, it brings a level of fear that from speaking to colleagues, the principals will understand the most. When you become a principal and you own a practice, and I own my business, but I don't own a practice, but I have a fear. I have a team of 8. I pay their salaries every month. That creates a level of fear that you will, that some people may never experience running your own business, because you have to pay the bills, you have to pay your staff. And sometimes and then when you make that investment in yourself, that itself is such a big fear. It's a good type of fear. That's going to drive you to make those changes. And I think the worst thing you can do is shy away from investing in yourself, and the worst thing you do is just go back in that shell and try and maybe just go with the flow and not progress. And I think if you stagnate, that's the biggest mistake you can make.
Yeah. Doing nothing shouldn't be an option. If in that scenario, in my belief, like, it's either you sort out your environment, sort out the people you're around, sort out yourself. But then that will enable you to go and hopefully progress and sort out your dentistry. But it's one
so
of
when
the
you
things
went
I
with
said.
the COIS is more like functional occlusion, treatment planning. It's the whole shebang, right? So
it's risk analysis.
To what
is the
extent
big
did
thing.
they cover sleep risk analysis? Yeah. Mm-hmm. So where did the sleep come in? Is that something that you got from COIS and you brought here, or is that something that you went to Australia, or you did other camps before you brought that back here?
Yeah. So basically, the airway thing, I was on like the second or third module at COIS. So there's 7 total. There was when I graduated. And they've changed it now a little bit because there's such a huge amount of demand, and also they're starting to be able to unleash some of the modules digitally online with VR glasses and all of that sort of stuff. It's actually quite amazing. So it's gonna open the world to people a lot easier. So basically, we were in a pub which is underneath the COIS Centre called the White Swan. So people that have been will know the White Swan is quite famous, and so. I was sat around with, I think, 2 Canadians and maybe 6 or 7 Americans, and we were all talking about what was dental school like, what was your debt like, what type of patients, NHS versus insurance, all of the usual chat, which is amazing, by the way. It really helped me appreciate what I was given at Leeds Uni, actually, because on reflection, maybe that's a different point. So we were having dinner and they mentioned this thing Airway. And I stopped them and I was like, guys, what are you talking about? Like, I literally didn't even understand the concept. Like, obviously I knew what the word meant, like, dictionary definition, but in relation to dentistry, I was like, guys, what are you guys on about? Airway. And they were like, they looked at me as if I had two heads. And they were like, what do you mean airway? And I literally didn't understand a single thing about it. I'd never come across the word in terms with dentistry. And they were all laughing. And I was like, fine, that's cool. Like, they're like, what do you guys do in the UK, And that was the first moment that I remember being like, okay, so there's something which I have no idea about. And then towards the, maybe module 6, module 7, John was bringing in airway screening and understanding. If I'm honest, I think the COI Centre was a little bit slow with the adoption of airway, but it's very much a part of their screening and their protocols now. And so don't forget, this was also 4 or 5 years ago. And airway is there are the bookends of treatment. It's the first thing that we need to screen and get our heads around, and it's one of the last things to make sure that actually we've given a therapeutic intervention to that patient and we've managed to help them. And so for me, airway is absolutely essential because it's letter A and it's letter Z of that journey of the patient through their dental work with me.
So let's talk to Aston at the White Swan. I think you said he's at the pub. Okay, so I'm Aston at the White Swan. Okay, I'm like, I've got these two heads. I'm like, airway? What do you mean airway? Okay, because you know what? There's thousands of dentists listening to this right now, watching this right now, and they are at that moment. Okay, we've all been there, and many are at that moment now where, you know what, they can do an MOD composite, they can make their occlusion just about fit, they can make some pretty resins and stuff, they can make a denture, they can take a tooth out. But airway was something that was kind of glossed over at dental school. Airway was like medical emergencies. When someone faints, you check their airway to make sure that you can give
ABC.
them CPR or whatever. That's what airway means to them. Exactly. What is airway and how is it relevant to dentistry in a nutshell?
Okay, so basically, the deeper levels of airway were taught to me by Riaz Yar and Aditi Desai, who you know very well. So basically, it's looking at a patient as a system. And so it forces me to take a step back, and I'm not looking at the white bits in their mouth. I actually don't really care about that initially. I'm looking at the person. I'm looking at their medical history. The patients have all the data. This is very much a COIS-driven thing. It's data-driven, and it's all about data acquisition and how I absorb it and how I process it. And so I need to gather certain amounts of data from the patient before they meet me. So we do that via questionnaires. There might be lots of different ways for people to do that, and photographs and scans before anyone comes in to see me. And then from there, I'm trying to place patients on different risk spectrums: periodontal, biomechanical, aesthetic, airway risk. And so I'm looking at their scans, I'm looking at arch widths, I'm looking at vaulted palates, I'm looking at tongue ties, I'm looking at what they've told me on their questionnaires. Are they feeling tired? Do they snore? Things like that. And so from there, that will help me lead my questions when I've got them for an hour. And so I will be able to then action some screening questions and work out if they're a high risk of having an airway problem or not. And just because you have a high risk doesn't mean you have an airway problem, but actually what you end up doing is you end up placing someone on that risk spectrum, and then I can deploy a sleep test if I need to, if I think it's necessary, or a referral to an ENT, or I can do some physical tests, like nasal breathing tests or swallowing tests. And those are all things that that have been taught to me by ENTs and airway-focused dentists and myofunctional therapists. And then at the end of all of that treatment, I'm now also able to start to work out actually any interventions that I've deployed, be it Myo, be it mandibular advancement device, be it tongue tie release, be it arch expansion, whatever it might be, has that patient in ENT referral, has that intervention been given some sort of therapeutic end goal? And that's the bit I love about airway, because actually I can get that buzz, and these are ways that we can really, really help people, Jazz. Yeah.
Amazing. So I've been helping with sleep testing for just over a couple of years now. It's been amazing to help screen for this, because we can't diagnose as dentists, we screen for this. and then to get them the right level of care, which sometimes is the CPAP or a mandibular advancement device, and how much difference it can make them. The patients say they're dreaming again, which is amazing. So all that kind of feedback that you've had, they're feeling more energetic. These patients are like on 3 different types of blood pressure tablets. You've been there, and no one's ever talked about how they're sleeping and if they're able to breathe and stuff. But here's an interesting perspective that when I listened to Jeff Rouse, and he did a podcast recently. I saw him in America recently as well at the AES. He's really fascinating in what he said on the podcast, which really opened my eye, and I'd love to hear your take on this as well. He says he likes to focus on the airway and not so much about the sleep so much, because the moment you go into sleep, as a dentist, you lose control. Now you are the tiny cog in the bigger piece, and you're referring to the sleep physicians, and they take over, right? And then that's it. Whereas he's saying that, okay, I'm focusing on the maxilla, okay? That maxilla belongs to me. I'm the dentist, okay? And so, and yes, exactly like you said about the whole tongue tie, the vaulted palate, that kind of stuff. So his philosophy is just do dentistry. And so that could be like MAPI, SAPI. So basically expanding the palate, even on adults, to allow them to breathe better. And that will have a knockdown effect on their sleep as well. To what extent, how are you operating? And tell me about what how the South Wales Dental Sleep Clinic, because the word sleep is there. Does that mean that you're primarily focusing on patients' sleep and therefore it's CPAP and mandibular advancement? Or are you then also working orthodontists for maxillary expansion? And then because we've got a varied audience, really talk to us like we're 12 years old and like, we're learning that, easing us into this amazing world that you're in.
Yes. So
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first
is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through Protrusive.app. So our best deals and free trials are only on Protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
In South Wales, I've set up a clinic which is predominantly online. It primarily is to do with the provision of sleep testing services. And the sleep testing services that we offer are multi-night sleep testing, because I needed to find out what was the platinum standard. And I, for about a year, was doing one-night sleep testing, which is great. You get a really huge amount of data, but you don't get patterns. And it's quite a prohibitively expensive thing to do multiple nights of single night testing. It just doesn't really make sense for patients to be able to do that. And so I was working quite hard at trying to work out, how do I overcome this? Because gold standard is multi-night testing. And it allows you to spot the things which are not the easy things to spot. You know, your mild, your moderate, and your severe sleep apneas are generally quite easy to spot on a sleep test. But your upper airway resistance syndrome and your restless leg syndrome, these fringe diagnoses, they're actually generally quite difficult to spot on a single night test. And the answer to that is multi-night testing. And it didn't exist in the UK, or a nice, easy service. So that is what I've created. I've created an online service basically for myself to be able to use. And now lots of other people are using it. And again, being gold standard, it's reported on by a sleep scientist. And then it's who does the diagnosis. And then we have an online meeting with the patients to actually go through the results in person, because it's such a customized model of health that I'm trying to give. I'm looking at the patient holistically. I really care about their medical history. Whereas actually, you know what, embarrassing to say, at the start of my career, I was just looking at, have they had radiation to the head? Are they going to bleed out? Do I really care beyond that? And actually the answer was probably no. And I've learned and grown from that now. So, and then from that, I am able to deploy ENT referrals. So I work very, very closely with an ENT, and also with, and we have now just launched the first myofunctional therapy service in Wales. So that's operated out of one of the practices that I work at, my sister's practice. And so they have in-person assessments, and then the rest of it is all done online, because actually the lots of different models that I've seen of myofunctional therapy, online myofunctional therapy, is the one that I think works the best for patients. And then from there, what actually has happened is I've been approached by a clinic in North London by a chap called Stefan Decker, who's the orthodontic specialist. And he has invited me to be part of his team. Him and his wife are both Coice grads. And so we believe, we don't know for sure, but we believe we're the only practice with 3 Coice grads in one roof, globally, in fact. And so the level of conversation, the level of treatment planning that we're able to deploy is phenomenal. And so Stefan actually is the leading light with driving forward an airway-centric approach. So he's a German dentist. So already the Europeans, as you said, the Australians, the Americans are miles ahead of us in the UK as an industry. That's not to berate the people who are doing airway in the UK. It's just to do with a reflection on the industry as a whole. And so Stefan being German, I mean, again, in his practice, he's got 3 myofunctional therapists working in his practice. I mean, go find that globally, let alone in the UK. So it's a real individual sort of mindset. And it's a holistic, full body, helping the patient. What the thing that they've developed there is now a new adult branch, which is what I've been brought in to come and to work for. So these guys are doing the MARPs, the SARPs on kids, adults, teenagers. They're doing dome. They're doing sleep testing services. So when I arrived in this practice and I was doing full mouth rehabs, which is my background, full mouth rehabs, which are then airway sympathetic. These guys were like, okay, cool. We were looking at some cases, and I was looking at their sleep tests, and I was like, dude, like these reports are awful, and these are also one night tests, and so they were missing things. And then And then they looked at me and they're like, okay. And then, so then I got them re-reported and my suspicions were right. And they were like, cool, you now have all the sleep testing. And I was like, I wasn't expecting this. Like, this wasn't the gig. Like, suddenly the sleep testing service was just set up to help me and my patients. And now suddenly a whole bunch of other patients and a massive thriving airway focused practice that are attracting people sort of internationally to flying into that practice now have all the sleep testing services done through me, which is a gift and a curse because I really wasn't geared up to dealing with that. And so it's important for people to understand that not everyone, for example, with a tongue tie needs it released, and not everyone with a vaulted palate needs it shallowing to increase nasal volume and things like that. It's just important for people to understand that you need to screen effectively, and the screening is going to come from two parts. One is from your eyes, so looking for these things, so that puts someone at a higher risk, and the information that you get gleaned from them through your questionnaires, that puts someone on a higher risk. And then you can have an informed conversation with that patient and say, listen, these are the things that you're telling me, and these are the things that I can see. And so these are the, so you're now on a higher risk, and that's okay. But because you're on a high risk, now let's deploy and let's get some data to actually work out if you have a problem. And if you don't, let's celebrate that. But if you do, now that can guide the rest of the journey that we're going to be going down. And so that was the thing that was initially, that was the when people were looking at me with two heads in America, in the White Swan, that's what they were looking at me and saying, wow, you're not even screening these patients, or you haven't even got the...
Aston, I've got a gazillion questions, and I was biting my tongue as you're talking because I was listening intently, and I think everything you're saying was brilliant. But I also listen to feedback on the show, and sometimes people say I interrupt my guests too much, and I was being respectful because you were saying such good, varied stuff. But I did want to stop you and say, hey, what is SAPI? What is MAPI? What is sleep apnea? And all that kind of stuff. So this is where we begin the little details to help everyone, because again, this is still a new space for everyone, and we come to you as the expert to help us to understand exactly what we're dealing with here, and how to begin unpacking this. Obviously, this is not going to make everyone an expert on airway and sleep and stuff, but this is like some other episodes, this is what gets people inspired. I've had so many people message me over the years, say, hey Jazz, it was your podcast that got me into occlusion. It was your podcast that got me into dental sleep medicine. And then they've said that before as well from the previous guests. And I'm sure the same will happen from this episode. They'll listen to you and say, you know what, I really like what Aston's doing. I love the idea of focusing on total body health, airway and sleep. So let's inspire them further. And I think the where to start is the following. Let's start at myofunctional therapy. Okay. So is this for children, or is this also for adults?
So first of all, you've inspired me, Jazz. So, this is me coming across as an expert. Also, that's very humbling because you've had such inspiration for me. So yeah, myofunctional therapy. So like the Myofunctional Therapy Society will want to lynch me for saying this, but the way that I explain it to a layperson is it's effectively physiotherapy of the soft tissue musculature. So it's about lip competence, it's about swallowing pattern, it's about tongue position and tone. And so myofunctional therapy is something where we focus on all the hard tissues generally as dentists, and maybe a little bit of the soft tissue, which is surrounding those hard tissues. But above and beyond that, the rest of it we don't really look at. So we look at pink, but only the pink, normally within about 5 or 6 millimeters of the zenith of teeth. And beyond that, the rest of the pink is pretty much ignored. And actually, if you look in the mouth and the head and head and neck, there's a lot of pink going on there. And so myofunctional therapy is something which I really don't know anyone that wouldn't have it or shouldn't have it, and you can't really do any harm. It's just an assessment of actually your current, like I said, muscle tone and swallowing pattern, who can have it, all the way from infants right the way through to 90-year-olds. There isn't really anyone that shouldn't have it. It's just the ability for the patient or the mother to be able to instigate it, or at least for an assessment, whether or not they actually have any exercises and do any treatment on a really small child. For me, my myofunctional therapists are the gatekeepers for me to refer for tongue tie release, not me. I won't do that. My myofunctional therapist will do that, just as my hygiene teams in all the practices that I work at are the gatekeepers for patients to have implants. They won't see me. They have to earn the right to be able to do that. And so I don't I don't prescribe treatments and hygiene appointments for my patients. I book my first appointment with a hygienist, and then the hygienist will do their own treatment plan, and I'll say, these are the set protocols that I need for this patient to return back and have this treatment completed, whatever it is, a full mouth rehab or just implants or whatever it is. Same thing with Myo.
So I like that you said that, because it helps us to understand, like, you want your perio stable before you do implants. That's where you employ your hygiene therapy team. That's great.
Yeah.
So before you, is it you who's doing the tongue tie, or you got oral surgeon on board who does the tongue tie release?
Yeah. I've got someone to do it for me at the moment, but if I'm honest,
watch this space.
Maybe 2028. I've got 2027 is full, but yeah. At the moment, I don't do them.
Okay, so basically, like perio to implants, the myofunctional therapists get the patients using their oral posture and tongue in the correct way first before they can get the benefit of the tongue tie release, which we'll talk about as well. But here's the thing: the typical patients that you are sending to your myofunctional therapist, are they generally younger? Because the philosophy I've been taught is that fix before 6. It's so important before age 6 to get them nasal breathing, have a look at all their sort of the pink parts, as you say. And I mean, for me, it's the most important thing that I've picked up is the whole nasal breathing. But what else is it that happens before age 6 that the myofunctional therapists help with? Because that seems to be a big push. But then I'll also talk about adults and which patients we should be finding a myofunctional therapist for adults and why. So essentially what I'm asking you is, what problems does myofunctional therapy solve, and how does that assist the dentist?
Yeah, so it allows, I'm not an expert at myofunctional therapy, but I work with them, and there's the main things that it solves is when patients have been compensating and the compensation is going down the wrong path. So there's the wrong nerves stimulating wrong the muscle firing. And so this can be assessed with swallowing patterns and breathing patterns and things like that. And at certain ages, especially before 6 years old, absolutely, in the words of Stefan Decker, catch them when there's the smoke instead of waiting for the fire when they're an older parent. So it's also to do with tongue form. So like I said, not everyone with a tongue tie needs it to be released, but the majority of people with tongue ties have very poor tongue form, and that tongue should be sat up and forwards, resting on the roof of the mouth, on the palate, both anteriorly and posteriorly, not just trying to get the tip of the tongue to the front. It's actually the posterior should be lifting up as well, because, as you know, the back wall of the tongue forms the front wall of your airway. And so if that tongue is down and back, the lumen is narrowed. And so you end up having much higher risk of having airway problems. And so when you have better tongue form and that tongue is set up and forwards, then that you're just making the system as good as it can be, which is why I said pretty much everyone, there's not really someone that shouldn't have it done, or at least not be assessed. Because what I say to my patients is, let's capture all the low-lying fruit. If I don't have to give you a mandibular advancement device, great. If I don't have to go and send you for surgical MAPI or SAPI or MAPI or whatever it is, or dome, great. I don't want to have to do it. Let's get your system as good as we can get your system and capture all that low-lying fruit for 2 reasons. Firstly, that might be the end of it. We could do myofunctional therapy, get that tongue out of the way if that was the original problem, and then you no longer have a problem. Your symptoms have improved. Amazing. High fives, done. All we've done is get your system working as good as it possibly can. But also, if we then need to move on to secondary things, then there's less therapeutic load for those interventions to have to achieve. And so, we might not need to advance you as much in a mandibular advancement device, or the CPAP machine won't need to be strapped on as tight and the air pressure ramped up quite as high, things like that. Or, it's also great as even if, say, for example, patients got sleep issues which are driven from nasal problems, so working closely with the ENTs, at least that tongue is out the way, their breathing patterns are better, they're breathing through their nose, so the general inflammation intranasally will be less, so they'll be able to assess that patient with much better eyes. There'll be less inflammation in there. So actually, does this person need turbinate reduction or not? Does this person, that sort of stuff. So it's just a no-brainer for me. And so it's easier for children, and children, it's realigning their compensation and the compensatory habits that their system has been adopting, and getting them on the straight line much sooner. Whereas as adults, it's having to rewire things. And as we both know, the neuroplasticity of adults is far, far less than the neuroplasticity of children. Yeah, that's why for me it was
Aston,
a
I've got some
non-negotiable.
patients who have an anterior open bite, and they didn't always have an anterior open bite, but they've developed it, had some major occlusal changes. I've taken CBCT of their joints. Their joints are healthy as anything, so they're kind of like self-deprogrammed, or just the way that they've grown is now they have an anterior open bite, but their front teeth used to touch. Now, one thing I warned them about is, okay, I can close the anterior open bite. I've got some wonderful cases just using clear aligners of how quickly and beautifully you can close these anterior open bites. And I show these cases on our course and stuff. But one thing I've always been wary of is the way they swallow and the way their tongue goes. Is that going to open that anterior open bite back up? Because there are patients, especially multiple diastemas, and you close them, and then they even break the fixed retainer because the tongue is too strong. Would that kind of patient benefit from having myofunctional therapy? Adult?
Absolutely. Myofunctional therapy for orthodontic stability is really, really important, because if you think about it, it's not just tongue. We do get too fixated with tongue with myofunctional therapy. It's like I said, it's all the pink. And so if you think the way that I explain to my patients is we know about this because we know about the neutral zone when we're making full dentures. And the neutral zone is where you have the musculature from the external muscles pushing in on those teeth on that denture, and you have the muscles from the inside pushing out, and that's the tongue. And that is where you want to place your teeth. And myofunctional therapy is basically the same thing. It's trying to achieve a healthy, stable, neutral zone so that the muscles on the outside are functioning properly and the muscles on the inside. And so ultimately, if that patient, for example, there's anterior open bites, that tongue is trying to like get out of jail. If that patient is compensatory swallowing and tongue thrusting because they're being suffocated, potentially hundreds of times a day, even just with resistance, then that's not a system which is harmonious. And so myofunctional therapy helps to achieve that and helps to get that musculature so that actually these teeth are sat in a better. But also on the flip side, Jazz, I've got similar patients now, and I'm like, well, I shouldn't have put those teeth where they are. I've tried to close those diastemas, and actually those teeth needed to be where they were in the first place. And so actually, is this a case that I need to jack back and close the diastemas, or is this a case where actually we might need to move them and place an implant, or we need to do some composite bonding on those teeth and actually not do it, work with the system as opposed to against it. And you said something earlier about the sleep and the airway and the maxilla is mine. I kind of a little bit disagree, because I am really, really loving the fact that as a dentist, I've been able to be exposed to a whole new world and working with ENTs and different surgeons and myofunctional therapists. And that has afforded me to actually partake in a little bit of a journey that I wouldn't normally be in. Like, it's a gift and a curse, dentistry, because we will usually see a patient, diagnose them, treatment plan them, execute it, maintain it. So that's all well and good. So everything happens within and so if you're a control freak, that's great. But actually for me, I get a lot of that with my dentistry, but also now this has afforded me to actually work as part of more of a medical sort of system where actually I'm just a cog. And actually, I think that's a gift and a curse, but I think there's a little bit of beauty in that, because I still have my other way of working, and I also have a new way of working as well. And I've built enough of a relationship now with the ENT, so I can say, listen, dude, can I come and sit in on these surgeries? Can I come and see what you're doing? Can I come and see a DICE, a drug-induced sleep endoscopy, so I can have a look up noses? How many noses did we get to look up at a dental school? None, because it wasn't our gig. But now I'm involved in that patient's health. For me, the driving factor is, listen, as dentists, we get to help people, okay? We get to get people out of pain. We get to deal with patients' sort of aesthetic concerns and their hang-ups with certain things about the way that they look. And we get our flowers and our hugs, and we're very, very lucky and I'm very grateful that I work in an industry where I get that level of soul nourishment. But as soon as I have tapped into the airway world, the ability that I can have a deep ripple with the impact of that patient's health and quality of life and happiness and is so profound. I haven't been able to find it anywhere near any other aspects of dentistry apart from with airway. And that is actually where my passion has come from. And this is the reason why I've just gone down a massive rabbit hole, because the airway was only ever part of full mouth rehabs and working out why these things were failing. And so this is the thing that I'm worried about loads of clinicians doing beautiful composite bonding and dealing with edge wear and things like that. And they don't understand why. This is the Coyce philosophy. Why has it happened? There is data there to work out why and how this happened. Why, for example, as you said, are my fixed retainers breaking? Why is there orthodontic relapse? And there is something driving that. And we're not very good at taking a pause and taking a step back and looking at the person. We're focusing on the broken retainer or the chipped composite. And why does my composite keep on failing lots and lots of times? Because actually, if that tooth originally failed, that tooth's been doing it for millions of years, right? Through evolution. And then we come along and we're, been doing modern dentistry for, 20, 30 years, something like that. And most of us qualified for maybe less than 15, that sort of amount of people who are going to be your listeners. And why do those teeth break in the first place? Why am I doing composite back on this tooth? And why is it, and how predictable, that's the other Coyce thing, how predictable is this going to be in terms of being able to last another 10 or 15 years? Because the material science shows us how long these materials should last for. So if they're not lasting that amount of time, predictably, then there's got to be a reason why. Airway often is a massively under analyzed and underdiagnosed thing.
I totally agree. And I gave you an example there of, yes, the patient who's got the anterior open bite. And then when you fix that, you also need to help them change the pattern of swallowing to help your orthodontic stability. We've already said mouth breathers, particularly children, mouth breathers, helping them to bring their lips together, breathe nasally. What other things should we be looking out for as general dentists to think, oh, you know what? That podcast is Aston Parmar. These are the things. Give us like a quick fire thing of 5 to 10 things, how much ever you can come to your mind, of children, adults that we as general dentists should be looking out for to work alongside a myofunctional therapist. And then later we'll talk about where you can find one.
Okay, so big things that any dentist should be looking at is familiarize yourself with something called the Stop Bang questionnaire and familiarize yourself with the Epworth Sleepiness Score. Those are very, very good quality screening tools, but don't deploy them to every single patient. It doesn't make any sense. The patients that you want to be deploying, simply ask them a question. How are you sleeping? Do you sleep well? Do you get off to sleep? So I just ask, do you get off to sleep well? Do you stay asleep for the whole night? Do you wake up in the morning? Do you feel refreshed? Okay, because generally you should do, if you've got healthy sleep, be able to get off to sleep with less than 30 minutes of sleep latency. You shouldn't be needing to wake up more than once in the night to go for a wee, and you should be feeling refreshed in the morning because that's the purpose of sleep. And so if those things aren't, then instantly that's going to lead me down a different pathway. And that takes me 10 seconds to ask those 3 questions. As the patient is going down in the chair, the first, and I always call my patients in. For me, I like to see what their energy is like. I like to see what their eye contact is like. And now I like to see what their lip competence is like. Jazz, you've got good lip competence. I've also been looking at you and watching you for the last sort of 45 minutes. And you're sat at rest with good, and these are the things that I'm looking at now. So then as the patient is going down in the chair, the things I'm looking for, you've got a split second to spot it. Ask them to open their mouth and stick their tongue out. Bang, that's when you can see the scalloping on the side of the tongue. Now, if their tongue has been out for quite a while, then actually the soft tissue just kind of flops and it forms the normal form shape of a tongue usually. But actually, if you can see some scalloping as soon as it pops out, that generally, again, increases one of the red flags for me in terms of pushing someone up that risk spectrum. Because actually, is that tongue being constricted by the jail cell bars that are the teeth? And so if they are, then maybe that tongue is being forced to sit too far back than what it should do. Then the next thing I'm looking at is the arch really narrow, or is it that they've got a really large tongue, or a little bit of both? And so, it could be one of those 2 things. First thing they do is when I get them to stick their tongue out, I'm also then instantly doing a Mallampati score. So Mallampati is from the anaesthetist world. He's an Indian anaesthetist who basically, how much of the uvula can you see, or how much of the uvula can you not see? And that sets a bit of a tone of how much space there is at the back of the throat. Again, it's not a diagnostic thing, it's a risk thing. It's more data for me. I do inter-arch recordings between basically cusp of Carabelli and
one
cusp of
interesting thing I
Carabelli.
just want to add in with Mallampati Score is And correct me if I'm wrong, Aston, for every one, so is it 0 to 4 grading, or is it 1 to 4? You have to remind me.
1 to
But
4,
like,
yeah.
I have it in my chart, my TMD assessment, but for every one score, 1 to 4, for every 1 point you are higher, it doubles your odds ratio of having sleep disordered breathing, is last time I'd read about in terms of relevance of it. Is that what you understand as well?
Yeah. I understand it basically in simpler terms. I just know it's exponential. Like, it ramps right up. So that's my take home from Mallampati. And then I'm asking the patient I want to know what their maximum gape is like. I'm doing their TMJ assessments. I'm looking at their maximum gape and then asking them, can they touch the tip of their tongue to the spot, which is basically on the nasopalatine foramen, without having to close their mandibles. So sorry about the listeners, but the viewers will be able to see me now. I open to maximum gape.
I'll describe. Go on. You do it. Open
and
all
I'm
the way.
able to close
all the
my
way,
tongue.
and then at the same time, while he's maximum open, yeah.
Yeah.
All right, let me try. You voice over what I'm doing now, okay?
Yeah. Okay. So yeah. Oh,
I had to close a bit.
Yeah. You had to close a bit. Yeah. You had to close a bit. So Jazz's tongue couldn't touch the nasopalatine foramen.
So how much of that is an issue? So for example, when I'm maximum open, go on.
Yeah. So it puts you just somewhere on that spectrum, slightly higher. So now I'm looking at it. So I'm not necessarily going to be talking to this about the patients. I will talk about it once I've pieced all the things together. I'm looking at, like I said, the width of the intermolar
Aston,
width.
You should be able to, in complete health, like a low risk, 0 risk patient for that one metric. So, for example, Mallampati 1 is good for the Mallampati, right? So, they open up all the way, they stick their tongue out all the way. You can see the entire uvula. Okay, well, that's of the so many things that we collect, the data that we collect is good to be Mallampati 1, okay? Obviously, everything has its own risk, so that's good. But when it comes to the test that we just talked about now, which is you open maximum and you stick the tip of your tongue by the nasopalatine foramen, ideally, you should be able to, the best is your tip of the tongue can go there without having to close. That's the ideal. So then what does that tell us about, okay, the more you have to close, how does that affect your sleep risk and how you are seeing that patient as a risk category? Yeah,
because now I'm seeing that actually they are much more likely to be having a tongue tie, be it an anterior or posterior tongue tie. And then at that point, I'm now thinking, okay, cool. So this tongue is more likely to have poor tongue form because it's been tethered for its whole life. And how easy and how often is it realistically sitting on the roof of your mouth? And so this instantly puts me into saying, this is likely going to lead me into saying, you are a patient that is probably going to benefit from a myofunctional assessment. Now, like I said, every single person with a tongue tie doesn't need myofunctional therapy. Every single person with a tongue tie doesn't need the tongue tie release. But actually, you're putting, these are sort of things that I would prefer to get. I would deploy an opinion from a professional because it just builds a picture of more likely to have pink-based problems, swallowing problems and airway problems and things like that. And now I'm asking the patients, are you having osteopathy? Are you having chiropractor work? Do you suffer with head and neck pain? I never used to care. I never used to really ask a patient about that sort of stuff. And I'm like, where is your pain? Where's your stress in your system? Because, there's a really good study and actually a very recent post by one of my mentors, Christian Leonhardt, who is a Khoisan Modjor guy. So I know him from 2 different worlds. And he put up a post about head posture and about every single centimeter further forward your head has to sit, the extra weight that your body has to hold like a lever. So, just as if you need to pick up a suitcase next to your body or lift a suitcase sort of horizontally with the arms out, like on a strongman competition, there's so much more tension held in. And quite a lot of the reason why people have a forward head posture is because of an airway issue, because they're trying to open their airway. So it's things like that I'm also seeing, in terms of posture of how these patients are walking in, bags under the eyes. I'm on the fringe, so I've got a little bit of upper airway resistance syndrome. As with most things in our lives, we start going down rabbit holes when we start diagnosing ourselves and looking at things about, and so, dark pooling, venous pooling around the eyes. That's one of the things. That's the other things I'm looking at.
The tip of my tongue stays on my nasopalatine foramen always, okay, like usually, so that's fine. But the back of my tongue has probably never touched a palate. I can tell you that right now. Is it supposed to?
Yeah, absolutely.
There we are.
Yeah.
See? So I'm going through all this now with my son who's 6, who's about to have his palatal expander placed now. And that was something that was assessed for him as well. And I'm seeing all this stuff in real time with the kids. And obviously he's 6. So I'm like, fixed before 6 and that kind of stuff. So here we are. It's fascinating. And why didn't we probably got taught that in the physiology anatomy lecture, like in one sentence, but in terms of the assessment and the importance of that and how that actually leads to the correct development of your airway. And this is why I had, premolar extractions, crowding, that kind of stuff. So all these things are, I mean, there's so much to learn in this field. And obviously this one podcast that we do, it won't do it justice, but what I hope it does do is inspire the next generation to go into this very rewarding field in terms of how much difference you can make to someone's life, how much focus you can have on their health, and sleep being one. Now, one thing you mentioned is upper airway resistance syndrome. Please tell us what that is.
Okay, yes. So basically, let's just bring it into something which probably more people understand, which is sleep apnea. So sleep apnea is generally going to kind of hammer your health in two broad ways. One is it's going to starve your blood of oxygen through your hypopneas. And the other thing that it does is it breaks up your sleep cycles. So it breaks up your small 90 to 120 minute circadian rhythms. You should be having 4 or 5 of those throughout the night. And then you have 2 during the daytime, which is why the Europeans are further ahead of us, because that's exactly when they have the siesta. And that's actually where that's come about from. So you have a 6-hour daytime circadian rhythm and a 90 to 120 minute nighttime circadian rhythm. And if your body is detecting that there is resistance or there is some form of drop in oxygen, your hypothalamus sends a fight or flight signal for you to gasp or gives you what's called a microarousal. And this is something which ends up breaking up your cycle. So you should be in a routine and a healthy sleep cycle going from a light into deep into REM. And that is one circadian rhythm. And if you're getting microarousals from your fight or flight part of your brain, then it breaks that up. And that is where people get chronic fatigue and really, really tired, but they're not getting so that is what happens in sleep apnea. Now, upper airway resistance syndrome, what you have to understand is all sleep is on some form of spectrum. So you've got sleep with no snoring, you've got light snoring, then you've got heavy snoring. So that is not disease. That is just social symptoms that people are either bothered about or not. Then you cross a very, very finite line, which is everything above this line now is into respiratory disease. This now needs appropriately diagnosing and also therefore appropriately treating. And it used to be generally everything above the line into disease goes straight into mild sleep apnea, moderate sleep apnea, and severe sleep apnea. But actually, sort of more recently, there's been an advent of people understanding that actually there are these fringe diseases which hover in and around that disease line, and one of them is upper airway resistance syndrome, the other is restless leg syndrome, and these are diseases which do not give you hypoxic burden. They don't starve your blood of oxygen, so you don't get all of those biological and chemical issues that come from that. Obviously, we know we're biological living animals. You don't need to be a medic or a dentist to know that we need oxygen to be able to function. But the upper airway resistance syndrome, your brain is still sending these fight or flight signals because it can detect that there is a narrowing of the airway. And so it's like, oh, we're on the way to our hypoxia. So it sends a signal and that breaks up your sleep cycles. So these are patients who have been suffering for years and years and years. They might not even snore very much, but they are not feeling refreshed. They're waking up in the morning and they are chronically tired, and they haven't been able to work out why.
So I have an interest in this, and so you've kind of self-diagnosed that you may have this, and I have once upon a time wondered as well. So when I did my sleep test, I had an AHI of 1 and 2. So AHI, for those listening, is, and you'll be the expert obviously, but apnea, hypopnea index. So how many times I stopped breathing per hour, or almost stopped breathing, or had enough resistance. But you'll explain it more elegantly than I will. But it was low. It was good. Like, so less than 5 is you're good, right? So 5 is mild. So that was good. And then I have some patients. I've got one active patient undergoing aligner therapy at the moment. And, you know, it's great when patients have these aura rings or all these sleep metrics, which we can discuss. And I geek out over that with my patients. I show them my Samsung Health data. They show me theirs. And so I love my patients who are into their sleep and that kind of stuff. And so I've got this one lovely gentleman that I'm treating at the moment. And for said, every time he's worn that aura ring that he borrowed from his friend, like, his sleep ratings were always abysmal. They were like always below 60 scores, no matter, even if he slept 7 hours, 8 hours, 10 hours, they were always broken up. He kept having these arousals that you can see in the graph, right? He kept waking up. It was a consistent thing. And then I did a sleep test on him before going further with him. And he had all these like constricted envelope, like wear, like really significant wear and stuff. And so Again, he had a sleep apnea, like AHI of 1 and 2, just like me. But I'm convinced he has something messing up his sleep, and I think it is upper airway resistance syndrome. So my question to you now is, what's the correct protocol for treatment for UARS?
Yeah, so basically with upper air resistance syndrome patients, in my view, is actually now the majority of my work. I'm so surprised. These are not your short, fat, middle-aged men that, people stereotypically think are the big, the grizzly bear snorers and they stop breathing and things like that. Obviously, people know about that and that's quite well known. But upper air resistance syndrome is something which is just exploded. These are your 30, late 40s patients. The majority of my work, a lot of them are women. There's more women suffering with this than with men. It's something which is very difficult to spot. Like you said, Jazz, you do a traditional sleep test and it will show that actually there's no hypoxic burden. In which case, great, no hypoxic burden. Mr. Jones, you've got respiratory health, off you go. But the reality is that it's showing that if you do a multi-night sleep test, that is the key. This is the thing that was missing for me as a service, and this is the thing that I've set up. If we're doing a multi-night sleep test, then we're able to now look and see patterns.
Well, there we have it, guys. Thank you so much for listening to Aston all the way till the end. And we just now introduced that cliffhanger, right? How do you diagnose upper airway resistance syndrome? How do you manage it? We cover that in the middle of part 2 coming next week. But of course, you can get the full CE or CPD certificate today by just answering the quiz and getting 80%. If you're on the app, just scroll down. If you're on protrusive.app, scroll down. If you're on Spotify or Apple, just close it down, open the app, and you can answer the quiz and play along and you get a certificate. Like, think of how many hours of CE you can accumulate for pretty good value just from your Protrusive membership, as well as being part of the nicest and geekiest community of dentists in the world. You also help to support what we do in our mission to make dentistry tangible. If you found this episode helpful, please spread the word, send it to a friend, but most importantly, tune back in for part 2. We go even deeper, more clinical, more about the implantation. When do you need to involve the ENT? What if you do a full mouth rehab and your patient has got sleep disordered breathing? Am I naughty if you just give them a mandibular advancement splint? How a regular splint, or let's say a Michigan or a Tanner, could actually be killing your patient, albeit slowly, but it could be happening. And that's why we always say screen for airway and sleep issues, something we talk about on Splint course as well, which by the way, you can access on the Ultimate Education Plan. And the final thing I want to talk about is our Ergonomics Day. Like, we don't have an annual conference, but this is as close as it gets, our annual gathering of Protrusive live and online. So I'd love to see you in person. It's on Saturday, 13th of June in Heathrow. I've got the world leading expert in ergonomics, Dr. Annika Ball, coming to London, and she's going to be teaching us how to actually sit properly, do our dentistry properly, how to position our elbows, how to position our back, that we can prevent back problems in the future. It's a very immersive workshop, and we're going to have a cameraman who's going to be blowing it up to a big screen so you can see every single angulation change. We're going to have a mobile dental chair. And one thing I saw Annika's post recently on Facebook, that just because you use ergo loops, that's not a vaccine for back problems, right? So ergo loops are great, but if you're using ergonomic loops and you're still twisting and bending your back, well, guess what? You're not actually getting the benefit of the ergo loops. So it's all about doing dentistry properly with the correct posture in mind, using the Alexander technique. And so I'd love for you to join us either online. You can get a ticket for the live stream and replay, or you can come in person. For those of us joined before the early bird deadline, you'll actually get a copy of the video as well. How cool is that? How often do you get to go to CE and then you kind of forget everything? Well, you're going to get a video of the event afterwards. Head over to protrusive.co.uk/unbreakable. That's protrusive.co.uk/unbreakable. I'd love to see you there in person if you can make it. But if not, come and join us online. Okay, thanks so much for watching all the way to the end. I'll catch you same time, same place next week. Don't forget, it's part 2 next week. Bye for now.